Thank you so much for that lovely introduction. Hi, I'm Dr. Hunchir Betty Zhang. The title of my talk today is A Pathway Towards Personalized Medicine in Pediatric Inflammatory Bowel Disease, or IBD. Here are my disclosures, none of which are related to the CME activity. Hopefully, at the end of this educational activity, participants will be able to appropriately evaluate patients with suspected pediatric IBD, differentiate the types of pediatric IBD, Crohn's, ulcerative colitis, and maybe hypothesize some areas of research for pediatric IBD since there is a great need. Since it's early in the morning, I thought that we would start off with a case to get us thinking. And unfortunately, this is the type of patient that we on the GI service are all too familiar with. This is a 15-year-old female with a past medical history of depression diagnosed at the age of 13, who presents to GI clinic with a 6-week history of diarrhea. The onset of diarrhea is insidious, subacute to chronic, really first off starting with 1 to 2 stools loose daily with no blood, and then developed into 4 to 6 stools a day that were blood-streaked. Finally, became that every bowel movement had dark blood mixed into the stool, and in the last week up to presenting to GI clinic was having 1 to 2 bowel movements at night that was waking her up. Upper symptoms include some nausea and maybe some excess flatulence. Lower symptoms include abdominal pain on and off, but no real emesis. She has had poor energy and has been unable to attend school over the last few days. So she's been seen by her PCP ×2 prior to coming into GI clinic. And I want to say shout out to the PCPs out there because without your work, without your proper referral, these patients get a little bit muddled in the system. So saw PCP the first time, was trialed on Zantac and Culturelle with minimal improvements. Second PCP visit yielded some blood work, a wonderfully comprehensive panel set done by the PCP. This blood work was done about 2 weeks prior to the GI presentation. CMP was done and was pretty much normal except for an albumin that was slightly low at 3.6. Lipase was normal. A CBC was done and showed some mild anemia. Get the pointer here. With a hematocrit of 34.9 and hemoglobin of 11.9. RDW and MCV were within normal range for age. A UA was done as well, that was normal. Urine culture subsequently was normal as well. And a stool culture was done, which was normal, along with the C. diff antigen and toxin reflex PCR, that was all normal. Inflammatory markers were done, and ESR was normal at 8, and normal is 0 to 20. ESR is erythrocyte sedimentation rate, a longer marker of inflammation for patients. CRP, C-reactive protein, which is a marker of a more of acute inflammation, is 2 for this patient, which was normal 2 weeks ago prior to presentation to GI clinic. Her medications include just Zoloft 50 milligrams once a day for a history of depression that was diagnosed again at 13 years of age. She's followed up by a psychologist and a PCP. There's no hospitalizations or ER visits for this condition for her. There's no family history of autoimmunity, IBD, or GI issues at all. Social history, she lives with her biological parents. She is in the 11th grade in high school, taking 2 AP classes and 2 honors classes, and has been missing school, which is causing some distress for her. Review system has been negative, except for some fatigue, diarrhea, abdominal pain per HBI. No joint symptoms, no rashes, no changes in vision, no fevers, no body aches, no URA symptoms, and no lymphadenopathy. So we go on to do a physical exam. Her growth has been trending pretty well along the 25th percentile without any drastic changes. Her height has been at the 50th percentile without any issues, and BMI has been steadily at 25th percentile. Z-score has been pretty consistently within range. Physical exam was pretty unimpressive. Vital signs were normal. She was a quiet adolescent female with clear sclera, no conjunctival injections. Her HENT exam was pretty much normal. Her chest was cleared to auscultation. Cardio exam was pretty much normal. Abdomen was non-tender with hyperactive bowel sounds present in all 4 quadrants, but there was no real guarding or any abdominal tenderness upon palpation. no hepatosplenomegaly, and the external perianal exam was normal at that time without any presence of anal fissures, drainage. Internal exam was deferred at the time because with that thorough workup by the PCP and that history, an EGD and colonoscopy with biopsy was ordered to be done within 9 days of this presentation for that urgent kind of diagnostic need. So she was then sent home from clinic. Unfortunately, one day after her GI clinic visit, Dad called the GI team. Her stools had increased up to 6 to 10 times a day now, and 2 times at night with 50% of the stool being blood. She became very tired and was sleeping all day, unable to eat anything. She was still hydrating small sips, but urine appeared dark. Fevers now developed up to 38.3 oral at home, defervesces with Tylenol, but would reappear again. Patient was instructed to go to the ER for an expedited workup and admission to the GI service with this kind of turn in clinical symptoms. In the ER, shout out to the ER doctors that help take care of our patients. Patient was tachycardic and dehydrated with a benign abdominal exam. Tmax now went up to 39.5 axillary. She appeared pale and more ill appearing. A normal saline bolus was given and maintenance fluids were started. Labs were drawn with blood culture, urine culture obtained, and labs showed chemistries that now look abnormal with electrolyte abnormalities, most likely secondary to stool loss, an albumin that is now downtrending down to 3, and a CRP that is now up 7.4 and an ESR that is 28. She is now further anemic with an H&H of 9.9 and 29.5 and now has a white count of 16.7. She also has a left shift with bands that's in the 6,000s. With this kind of history, rapid infectious stool studies PCR panel was sent and a C. diff toxin and antigen and toxin reflex PCR was sent. Patient was admitted to the GI service with IV hydration, 1 times IV fluids, and clean out for inpatient scope. In the meantime, the blood culture, the UA, the urine culture, and the stool PCR and C. diff all came back negative. On hospital day 1, although the initial H&H was reassuring at admission, drifted down to a hematocrit of 23.2 with some symptoms of dizziness over 24 hours. Patient was transfused 1 unit of PRBC with a repeat crit of 31.5. A gentle clean-out, and yes, this is not our usual clean-out, was begun with Miralax 17 grams TID in the consideration of the diarrhea and electrolytes. Maintenance fluids were continued, and then electrolytes were checked daily while on this clean-out and fluid status. Hospital day 3, after 2 days of a gentle clean-out, the patient was scoped. So here, in the upper right-hand corner is not the patient's colon. This is what a normal colon should look like. It is nice and pink and smooth. You can see beautiful vasculature patterns, and you can see folds. The triangle shape, usually when we see it, we think it's transverse colon, but this is just a reference picture to show you because our patient's colon, left and right, do not look like that. Does not look like that. There is no normal vasculature. There is no pink. There is all red. There is extreme friability. There is ulcerations. There is blood, and there is just a lot of edema where you can't see the folds anymore. So left and right colon, her entire colon looked like this, and her terminal ileum appeared normal. Folds are back intact, the villi are present, and no ulcerations seen. So with this picture, endoscopically, a diagnosis of ulcerative colitis, pancolitis, was made. And I will say for us, endoscopically, we can make about 95% of that diagnosis for IBD. The last 5% comes down to the biopsies that we wait for to make sure that there's no surprises there. So, with that diagnosis, patient was started on methylprednisolone, 1 mg per kg per day after the scope with the PPI prophylaxis of omeprazole with the start of steroids for gastric protection. Prior to Immunosuppression or further immunosuppression, we do want to make sure that we check vaccine status to make sure that prior to giving anything, because if they start anything like a biologic, they are not allowed to get any kind of live vaccinations. We also check TB status with quantiferon TB gold testing. That was negative for this patient. And a TB-MT metabolize enzyme level to make sure that this patient can be started on azathioprine if we need to. We started a PUCI, that stands for Pediatric Ulcerative Colitis Activity Index score, every day to see how well the patient does, and that is a objective score looking at pain, rectal bleeding, stool consistency, number of stools a day, nocturnal stools, and activity level. The score ranges from 0 to 85, and 65 is already pretty severe. So this gives us an objective measure of how well the patient is doing day to day. And the biopsies came back pretty quickly, consistent with ulcerative colitis, no surprises. So steroids were continued for 5 days. Unfortunately, after 5 days of IV steroids and inpatient stay, with IV hydration as well, the PUCI was not improving. Ranges still were 60 to 65. At that point in time, because of steroid non-responsiveness, IV infliximab or Remicade was given. Finally, at hospital day 12, the PUCI responded down to 25, and that is mild disease. So that huge improvement made us feel pretty good about discharging the patient on a prednisone wean and omeprazole to follow up outpatient. Infliximab infusions for maintenance were continued and scheduled, and a Hep B booster was given for non-reactivity. Luckily, the patient followed up in clinic about 7 days after discharge. Labs looked improved. Patient was started on PO iron in addition to a steroid taper and a PPI taper. And the patient continues to do well on infliximab infusions at the 3-month follow-up time point. So a pretty happy ending for this patient so far with this hospitalization. But I wanted to bring this case up because it does demonstrate how pediatric IBD can present in both in a subacute chronic way, but then have a rapid worsening of symptoms, and you just don't know which way they're going to go. It also exemplifies how refractory some forms of IBD can be and how quickly we need to recognize how they're doing, hospitalize, and then change therapy if we need to rather quickly. So now let's talk about pediatric IBD and obviously why we care. So this is a figure that's probably pretty familiar to you guys. This is a figure from 2002, and it shows that autoimmunity seems to be on the rise since the 1950s. Back in the 2000s, about 1 million people in the US had a diagnosis of IBD, with an annual incidence of 8 per 100,000 person years. Let's fast forward to last year, 2023. Now, that number, 1 million, remember, has now almost tripled. Up to 2.7 million people in the US now have IBD, with an annual incidence of 11 per 100,000 person years. And us as pediatricians, we care because about 20 to 25% of those incidences occur in a time of childhood, and we obviously need to recognize and treat them appropriately as this is a time of growth. All this data was taken from Medicaid, Medicare, and commercial insurance. This was published last year in Gastroenterology, and it kind of really makes us wake up and see how important this is. IBD is present across all races and geographically across the US. You can see that there is no kind of gap in terms of who gets spared. And there is an increase in the Northeast, however, it is definitely present throughout. And that is true at our institution. So this is data from our own institution at the IBD Center from 2013 to 2019. The orange bars are return visits for IBD. The blue bars are new visits for IBD. Unfortunately, the pandemic with telemed, we're unable to kind of extract the data for return and new visits for IBD past 2020, but you can see those numbers are rising, and we continue to see an increased incidence and prevalence of pediatric IBD at our own center. Some of the resources that we have set up at our IBD Center, we have an IBD team that meets every Wednesday at 1 p.m. to review all the inpatient cases with the inpatient team. We have outpatient complex patient reviews as well, and we give each other lectures to make sure that we are on top of what's new in the literature and what medications are coming down the streamline. We have a website for anyone who is interested. This is both internal and external. To kind of take a look at what resources we have and also what kind of research we're doing on an individual basis. For our new patients, we have our wonderful RNs. Shout out to the GI RNs to do education, injection support for medications like Stelara and Humira. We have an IBD new diagnosis binder to kind of go through with new diagnosed patients, and a Nimble comic book for those patients that want to read a little bit more about their diagnosis. We also have an advanced fellowship training in IBD for those GI fellows that want to do an extra year to learn a little bit more about pediatric IBD, established in 2022, and we graduated our first fellow this past year. Clinical and translational research is at the forefront of our IBD center. Intestinal ultrasound is a modality that we can provide in clinic in real time to take a look at mucosal thickening when the patient is there, so that we can save them a trip either to radiology or to the endoscopy suite for a more invasive procedure and longer procedures. And we are also studying mucosal immunology related to IBD, which I will talk about a little bit later. Crohn's Colitis Foundation is perhaps the most fun out of everything on this slide. This is the Northwest chapter for the Crohn's Colitis Foundation that we are all a part of, and we help run Camp Oasis, being in the medical tent, where all the patients that are diagnosed with IBD can come together during the summertime and share their stories and just have a good time and just get to be kids. Okay, so for our first objective, we're going to talk about how IBD presents. I think for all of the trainees out there, we all have heard this before. IBD is a chronic autoimmune disease affecting the gastrointestinal tract. We are taking a clinical history, which can yield abdominal pain, diarrhea, bloody stools. Which is extremely important to see is growth delay can be present without some of these symptoms. So growth delay is a big one that we need to take into consideration when we take a history and physical. Laboratory studies, like our patient that I presented earlier, CBC, chemistry, ESR, CRP. Calprotectin is a stool marker of inflammation. Although we like it, it's not always necessary to make that diagnosis because the gold standard is an upper endoscopy and colonoscopy with biopsy. Without that, we can't make that diagnosis. Stool calprotectin is also nonspecific, meaning if you have an infection or something going on that's irritating your gastrointestinal tract, you ate something funny, coffee didn't agree with you, that number can actually go up as well. Imaging modalities to look at the areas of the GI tract that we cannot reach with our scope include a CTE, that's a CT enterography, an MRE, an MR enterography, and capsule endoscopy. And this is done in conjunction with the gold standard EGD and colonoscopy with biopsies, not standalone. One of the really important things to keep in mind is that enteric infections can mimic IBD. So like our case prior, remember rapid stool or stool cultures were checked like twice before we went ahead for scope. It is important to rule out infections as Campylobacter, Shigella, Salmonella, Yersinia, any of the E. coli's can really mimic bloody diarrhea in our patients, and we want to make sure that we treat appropriately prior to doing a procedure with biopsies. In our panel, the rapid stool PCR at Seattle Children's, and this is kind of really nice that we have not only bacteria captured, but we have Cryptosporidia, Cyclospora, Entamoeba giardia, and then a list of viruses that are also tested off of one stool study. This may not be true across the board in some hospitals in the community, but we do have that kind of capability here. C. diff, antigen, and toxin reflex PCR are not in this panel, so you do have to order that separately as well. So again, what are the two types of IBD? So again, this picture up here is normal, not IBD. Like our patient who has ulcerative colitis, you can have ulcerative colitis with colon-only involvement in a continuous pattern from rectum up. ulcerative colitis, by definition, has only mucosal inflammation, which means it should not go through all the layers of the gastrointestinal tract, and there should be no granuloma seen on H&E pathology. Crohn's disease. Any part of the gastrointestinal tract can be involved. It can be a discontinuous involvement. It is a transmural inflammation, meaning at some point in time this can lead to fistulas, abscesses, strictures, and there's sometimes perianal involvement as well that can be very painful. Commonly the ileum is involved, and on H&E you can see, sometimes, not all the time, you can see these non-caseating granulomas that help distinguish between Crohn's versus ulcerative colitis. There is one more entity called indeterminate colitis. That's where they have elements of both, and us as clinicians are not fully sure of the diagnosis, but that's something for us to figure out. Just because there's two entities doesn't mean that they all look the same. So, for example, with pediatric ulcerative colitis, you can have different forms of UC. You can have pancolitis, just like our patient, that involves the entire colon, and that's 77% of presentation. You can have left-sided. For some reason, the inflammation stops, usually at the splenic flexure. And then you can have proctitis, meaning just the rectum is involved. And you can see that symptoms can be different across the board. Usually our proctitis patients complain mostly of tenesmus urgency, whereas the pancolitis is a little bit more diarrhea, abdominal pain. So area of the GI tract affected is very important to consider when you have these patients. Crohn's disease gets even more complicated because you can have any place of the gastrointestinal tract that can be affected. Ileal only can be present in 16%, colonic in about 30%, ileocolonic 50-something%, and then just upper disease about 4%. Why are these things all different? We don't know. Hold on. There. Because we're all pediatricians, growth, right? We all care about growth. Growth failure, linear growth failure, is unfortunately very common in our IBD population. About a third of pediatric IBD patients will present to us in growth failure already. So it's an important parameter and a sensitive parameter to measure. In those patients that have not hit puberty, growth failure or linear growth failure can be present in 60 to 85% of those patients prior to treatment. In UC, not as bad, but definitely something that we need to keep an eye on as these patients grow. Another thing to mention is that symptoms of depression or anxiety are extremely common in patients with IBD. A report in about 2006 showed that 25 to 30% of patients with IBD have symptoms of depression and or anxiety, which are similar to children with other chronic diseases. So that was pre-COVID. After COVID, there's another Danish study in 2024 that showed that studied a registry, the national registry, of about 3,000 patients with pediatric IBD, and a control cohort that was age-matched, that was 17,000 patients, looking at the risk of depression and antidepressant use. And you can see based off the Kaplan-Meier curve here, and this is a little bit confusing, the red is IBD population, the blue line is the referenced individuals, and this is on the y-axis proportion without depression contacts. So as you go further down, you have more depression contacts. Over the course of the x-axis is number of years that you have your diagnosis for. So it seems that depression is 50% higher risk in our IBD patients, and there is a 50% higher risk of using antidepressants. So why do I bring this up? Because as we all know, screening for mental health in any patient, in our IBD patients, is extremely important. And honestly, we at the IBD Center, and I'm sure all the pediatricians agree with me, we need more mental health resources for the long-term care of these patients. We can identify some things, we can certainly screen our patients, but it is so difficult to have these patients appropriately seen sometimes. So extremely important to continue to monitor in our pediatric IBD cohort. Okay, so I will not go into therapies too much because this is a little bit beyond the scope of this grand rounds, but I do want to kind of say that it is the number of therapies available since the 2000s for pediatric IBD has really skyrocketed, which is awesome. So before the really 1990s, steroids and immunomodulators and mesalamines were very commonly used, methotrexate, azathioprine. Since really the anti-TNFs with infliximab, which is Remicade, adalimumab, Humira, golimumab, have been approved for use of inflammatory bowel disease, it's changed the landscape of the options that we have for IBD. We continue to have more options with vedolizumab, ustekinumab, tofacitinib, and no, this will not be on your test, ozanimod and risankizumab. But really, just remember that of the medications that we have, maintenance treatment has a 50% failure rate in 2 to 3 years. And if you're looking at patients that we follow, and some we follow for like 20 some years, that's not good. So understanding which medication to use at the forefront and which medications, if we need to change to, is definitely something we still are trying to understand. And that's why I think research is much needed in pediatric IBD. For me, just off the top of my head, what are the really immunological and cellular signatures in the various forms of IBD? Because we know that it's not just Crohn's and ulcerative colitis. There's different subtypes within each one. Are there predictors of response to therapy, and which therapy can we be using, given the failure rate? Who's going to need surgery? Because some of our patients do need surgery at some point in time for those strictures and for those non-responsive colitises. And then can we develop some new biomarkers of mucosal healing? Because every time we need to see if someone's responding to immunosuppression, we actually have to do an endoscopy, which requires time, sedation, and of course risk. So with those questions in mind, my team and I had launched Predict over the last 8 years now, which is a multi-center prospective clinical trial located in both Boston Children's and Seattle Children's, enrolling naive to treatment pediatric IBD patients with subsequent clinical follow-up and blood follow-up, along with anytime they need a repeat scope, we get biopsies as well. So over 3 years, we're able to monitor and see who needs escalation of treatment or change of treatment. We take these tissue samples and blood samples, we're able to dissociate everything down to a single cell level, and we run them through the 10x genomic platform using 3' and 5' and flow cytometry as well. We're up to about 120 patients at this point in time. Off of our first publication, we're able to look at 14 Crohn's disease patients. This is naive to treatment, meaning prior to starting anything. Some of them responded well to anti-TNF, others did not. This is a small cohort, but it's something. And a control, age-matched control, non-inflamed cohort, 13 patients. So looking at the demographics, the genders are the genders are matched in both cohorts. BMI Z-score is matched, and then age is also matched. Not surprisingly, your ESR and CRP are way elevated in our Crohn's disease cohort. So off of those 14 patients, this is just the kind of first set of data that we're publishing from this Predict project. We're able to look at lamina propria terminal ileum cells. And this, for anyone who is not familiar with the single-cell RNA-seq space, this is what's called a Tisney plot. Each dot is a cell, and each dot is clustering, meaning they're kind of coagulating together to an area where it's most like its neighbor cell. So for example, your T cells are in teal, your B cells are in blue, and your epithelial cells are in green. Here, these are the different patients that make up this whole Tisney plot. With further kind of manipulation, we're able to then look at the tier 1 clusters, which cells are what, and look at the transcript expressions within each of these cells. And we can actually subcluster further down. We use Arbo, which is a software program using Seurat4 as an input to generate a random forest algorithm based on unbiased clustering, based on similarity of gene lists to produce what's called a dendrogram. Yes, please put on your glasses. No, just kidding. These kind of, you can see tier 1 kind of subclasses out into further classes of cells and cellular interactions and cell states of activation or deactivation. We can then complete gene lists and calculate what cell clusters are present across the board. So 2 cohorts, Crohn's disease and controls. Within our Crohn's disease cohort, we can see that there's 305 clusters recovered as end states, and within our controls, this is the non-inflamed controls, 118 clusters are recovered. This is most likely be due to the fact that in Crohn's disease, you have just a lot more activation of cells, so different cell types are activated and different cell clusters are present. We can then compare and contrast who's there, who's present, and who's responding to anti-TNF. And as we go through each cluster one by one, I won't bore you with the details, but we are able to look at both Crohn's and control and response to therapy. We're able to see that there is a vector called TIME. That's T cell, innate lymphoid cell, myeloid cell, and epithelial cell. This is a cluster, a group of cells that seem to stand out in those patients that have an anti-TNF that does not respond to anti-TNF. And so we're then able to plot them on a Spearman rank correlation with principal component 1 to show that there is significant difference within this grouping of cells that seems to drive disease signature states. So those who do not respond seem to have a different look than those who do actually respond. And this is, again, from biopsies prior to treatment of the patients. So here I think we can start, and again, this is a small cohort. This is like 5, and 4. This is a small cohort of patients that we're able to look at to decipher who do we need to start on anti-TNF and who do we need to start thinking about, is there something else to be starting on? So within that, my conclusions are that IBD is a growing healthcare issue, increasing in incidence and prevalence across the board. New therapies are on the horizon, but positioning these new therapies is still a question, and refractory states of disease definitely still occur. Using single-cell RNA-seq, we found a vector of TIME, that's T cell, innate lymphoid cell, myeloid cell, epithelial cell, of differences in the naive to treatment pediatric Crohn's disease patients that seem to respond to anti-TNF therapy down the road. And again, further work is needed to begin tailoring therapies based on the immunotypic landscape of the target organ, the gastrointestinal tract, and IBD. And upon further work, we are actually, the IBD team at Seattle Children's and the Allen Institute downtown launched this collaboration, which is really exciting, back in May of 2024, to look at really the next step, I would say, of immunological techniques, to look at tissue samples from the naive to treatment patients with IBD. We're hoping to use multiple immunological techniques off of one piece of tissue to look at spatial transcriptomics using Visium and Xenium from the 10x genomic platform, proteomics with CellDive, and then cell-to-cell interaction using multi-scope confocal microscopy. We're hoping to enroll about 200 patients with newly diagnosed pediatric IBD. We are on our way with 11 so far, but on our way. This is just some really cool data that has come out recently. This is all pilot data looking at terminal ileum. This is protein expression, looking at just some markers, epithelium, smooth muscle actin, CD45, which is your leukocyte and marker, and then DAPI is your DNA. Looking at how uninflamed TI looks like this. This is upon endoscopic evaluation. Moving on to the spectrum of inflammation that looks like this. You can see that there's CD4 infiltration throughout that piece of tissue. And so we are able to kind of gather some data from a protein perspective, but also we're able to gather data from a transcript perspective, as some of the cytokines are really hard to measure in the tissue. So we were able to see what the transcript expressions look like in areas of inflammation versus areas that are not inflamed. And with that, I will stop and thank first and foremost the patients and family who have participated in this research, the physicians here at Seattle Children's, Dr. Ghassan Wabe, the medical director of the IBD team, Dr. Lucine Ambartsumian, Dr. David Suskin, Dr. Dale Lee, our research coordinators that are right here in this audience here, Mason Nuding, Danny Kagakis, there you are, Natalie Lang, thank you for all that you do. Our collaborators at the Allen Institute for Immunology, Dr. Troy Torgerson, Dr. Adam Savage, Dr. Claire Gustafson, and Christy Bennett, and all my collaborators back on the East Coast and the Boston side with the Keene Lab and the Ordavas Montañas Lab. Thank you.
Thank you. Just a reminder to everyone in the audience and online, if you can fill out an evaluation, you can use the QR code that you're seeing on your screen, or if not, you'll be sent one later. And now I'll open things up for questions. First in the room, if you have a question, feel free to raise your hand. Thanks.
Thank you so much for such a great presentation. I remember learning classically that there were certain types of IBD that would present with a higher risk for patients over time for certain types of cancers. And I'm wondering, number one, is that still the case? Does it happen in childhood and adolescence at all? And also, do these new therapies that are now coming into play, is there a possibility that those will impact that?
Yeah, great question. So, we aim for mucosal healing, meaning there's inflammation, we treat it, we go look again, and everything looks normal, and on biopsy looks normal as well. That's our gold standard of saying that we've fully treated IBD. Your cancer risk in any area of inflammation does go up, so continued inflammation does increase your cancer risk, colon cancer, small bowel cancer in general. Usually when we think about cancer risk, it's the ulcerative colitis patients that we want to continue screening for every 5 to 10 years, depending on risk. But really, uncontrolled inflammation is the driver of any kind of changes, any development of cancer cells that may develop over time. In terms of the question of, do these new therapies lead to mucosal healing or better mucosal healing? It's hard to say because they're so new at this point in time. Anti-TNF just came to market really in 2000, and some of these newer agents, tofacitinib, some of the smaller molecules just came to really our kind of ability to use them over the last 2 to 3 years. So time will tell. We're hoping that, it'll do better than what we have available, but it's nice to have options at this point in time because unfortunately these kids, and I don't know what it is, I think it's because their mucosal immune system is still developing, still changing. They're being exposed to all these different antigens, right? Whereas us, we're kind of used to that. So I think there's almost like an escape of the immune system even when we do immunosuppress these patients. So I hope that these newer agents are going to aid us.
Thank you so much for this fantastic talk and wonderful research. As a general pediatrician, I'm always interested in why are the rates going up, and is there anything that we can do to prevent it? Particularly, I know in some of the other areas of GI medicine with celiac disease, and thinking about, are there dietary factors or other things that we could either screen for or think about as a prevention for developing these really difficult diseases in the first place, and I'd love your comments on that.
That's a great question. That's like another 3-hour lecture of a question. I think right now there's not one thought, or not one thing that we can point our fingers to say that it's because of this. Certainly the increased amount of preservatives in foods, increased amount of detergents that are in our foods, probably do have something to do with it. Which one exactly, I can't tell you. There is also data suggesting that sunlight and vitamin D may have something to do with it as well. I don't think that's the full story, but there is that increased spike in the northeast that you can see here. That is there. Obviously, genes also have something to do with it, not the whole story, again, because monozygotic twins, even if one twin gets it, the other twin is not 100% getting IBD. So microbiome, antigen exposure, weather, I do think there's a lot of factors that go into it. I can't point my finger as to which one exactly. I don't know if that answered your question or not.
You can come back next year and give us another good round. I have a few questions from online folks, and then I'll open it back up to the room. From Dominique Mark, how do you envision the landscape of IBD therapy evolving as we gain better understanding of immunologic pathways? What challenges do you anticipate we may face with future therapies, understanding that a significant percentage of patients lose response to biologics?
Thank you, Dominique, one of our pharmacists. Great question. So, insurance is always a problem, right? Finding insurance authorization is like half the battle that our nurses do in the back end. So, even if something like ozanimod is available or upadacitinib is available, it's really hard to use it first line for some of our patients without doing clinical trials, which Ghassan Wabe is actually doing clinical trials in some of these medications. Number one, I think insurance needs to change. It's not, it seems that there's so much red tape in us trying to prescribe certain medications, so that it kind of forces us to use some of the older agents first before exploring some of this. I think that of the data that's out there, and again, these things are quite new. So in pediatrics especially, it's not like we've had 10 to 12, 20 years of experience in any of these. But from what we've seen, it seems that these therapies do seem to be working, even on those refractory patients that have failed some of the other agents that have been trialed before. So I'm hopeful that maybe we'll be able to see some improved efficacy in some of these medications. Now, I will say that, again, the immune system is changing in someone who's growing, right? So I would love to pinpoint and say, if we can start the patient on just one thing, monitor it over time, make sure that one thing is still working over time, I think that would be the key in terms of truly personalizing some of these treatment options.
Thank you. And one more question online from Donna Deno. Thank you for a wonderful talk. Do you believe that the linear growth faltering in IBD is related to chronic low-grade systemic inflammation and or malabsorption?
Great question. Yeah. So I think that's because there's definitely some malabsorption happening. And you notice that it's the Crohn's disease patients, not all of the UC patients, that are at risk for linear growth. They, all are, but, it seems that it's more impressive in the Crohn's disease cohort. And that's because Crohn's disease, again, skips around, and ileum is usually involved. And what does the ileum do? It absorbs nutrients, it absorbs your vitamins, and it absorbs a lot of the things that we're putting into our bodies. So I do think that if someone has Crohn's disease, it's something always to be monitoring. With UC, because it's colon, and what is colon responsible for? Usually fluid absorption, electrolyte balance. So it's not quite as important in UC, although we do make sure that, there's continued follow-up.
That was such a great presentation, just whittling down so much really dense information down into a very concise summary. Just because I know that your area of expertise in very early onset IBD patients, that's been a really evolving population. I wonder if you could speak to that a little bit and what's available for those kids.
Thank you, Evelyn. So the very early onset inflammatory bowel disease patients are those patients that develop IBD before the age of 5 to 6. And before 2, we start thinking, is there some sort of genetic defect involved? Honestly, if any IBD patient's not responding well, refractory to multiple treatments, we have to think about, is there some sort of genetic defect involved? So we tend to collaborate with our immunology colleagues. Dr. Maite Della Morena has been really tremendous in leading the very early onset IBD cohort momentum in terms of seeing what other tests we need to be doing for those patients. So we do have a gene panel, ImmuneSeq, which looks at, I think, over 400 genes to see if there's any monogenic defect in the immunity of these patients. And we've actually caught a few XIAPs in our in our refractory IBD patients that we would never have thought about before. And that kind of changes the thought process, right? You start thinking about how do we treat this immunological defect versus IBD alone. And that's something that I think at some point in time, we do need to start thinking about, does everyone with IBD deserve testing to see if that changes the trajectory of how we treat? I do think we have a lot to learn from our immunology colleagues in terms of what defect goes with what and how does it present. So ongoing research in the very early IBD onsets. We're hoping that eventually we'll have a really big cohort to actually ask questions about as well. There's more research to be done in that as well.
Hi, thank you so much for this talk. I had a question with just with treating these patients in the inpatient side, whether it's acute, chronic, acute on chronic. Is there a standard care of pain regimen that is appropriate? I always want to be mindful before using opioids, but also want their pain to be addressed.
Yeah. So, we try to, with our patients, like the acute severe colitis patient in our case this morning, we try to use non-opiate medications, Tylenol, usually not Motrin. So, we try to do around-the-clock Tylenol as we can. If we need to, we do use nalbuphine IV, or I don't think there's a PO form, but IV as needed. Being mindful of how many doses they need, and we are, it's not just treating the pain, it's if they are in more pain than what they came in with, we're also thinking about did something happen in their GI tract. So in addition to treating the pain, we need to be assessing the patient as well, and making sure that they didn't develop toxic megacolon or have a perforation secondary to their disease state. Just making sure that although we address pain, that we're addressing whatever is underlying the pain as well. So yeah, nalbuphine we do use, but we try to kind of maximize the Tylenol pathway.
Thank you so much for this talk. On the demographic slide, it mentioned like the all race sort of breakdown. I noticed that Native Americans were missing, and I wanted to ask you if there was any like information on how this affects Native Indigenous populations. Very
good point. Very good point. So I know that from our center experience, we definitely do see Alaskan Natives with IBD, and we also see, or descent, we also see Hawaiian Natives with IBD as well. Unfortunately, this is a population that was, I didn't see it in the paper itself. I can look again, but I don't think that the Native population escapes having a diagnosis of IBD. Yeah, I'm sorry that this is not mentioned here.
Thanks. One more came in from online from Peter Colrose. Nice talk. Are children with IBD more likely to have inflammatory disease of other organ systems?
Ooh, great question. I didn't think that I was going to have time to mention that slide, but so yes. So we can have, we pair with rheumatology a lot. We're always talking to our rheumatology colleagues. So joint symptoms, sometimes related to IBD, IBD-related arthritis, arthralgias, certainly. Chromo, okay, that's, if anyone, chronic osteomyelitis. Thank you, chronic recurrent osteomyelitis. Correct me if I'm wrong. It also occurs in our population. Psoriasis, sometimes medication-induced psoriasis, but psoriasis are also present. So this is something that we definitely keep track of. Uveitis, episcleritis. We always recommend that our children go get ophthalmology exams every year. And if there's any kind of chronic joint symptoms, we refer them to rheumatology rather quickly. And hepatology as well, because they can also get autoimmune hepatitis and PSC, primary sclerosing cholangitis.
Thank you so much, Dr. Zhang. This research is incredible.